Historical overview of antimalarials in systemic lupus erythematosus management. Early use, 1930s to 1940s. The antimalarial drug quinacrine was first used to treat lupus and other autoimmune diseases. The discovery that these drugs could modulate immune response led to their use in autoimmune conditions. 1955, hydroxychloroquine, Plaquenil, was introduced as a less toxic alternative to chloroquine. It quickly became a preferred treatment for SLE due to its efficacy and better safety profile. Mechanism of action. Antimalarials like hydroxychloroquine and chloroquine work by inhibiting toll-like receptors, TLRs, and interfering with antigen presentation and cytokine production. These mechanisms reduce autoantibody production and decrease inflammatory responses. Clinical efficacy and benefits. Symptom management. Antimalarials are effective in controlling mild to moderate SLE symptoms, including skin rashes, joint pain, and fatigue. Disease modification. Long-term use of hydroxychloroquine has been shown to reduce disease flares, lower the risk of organ damage, and improve survival rates. Cardiovascular benefits. Hydroxychloroquine has been associated with a lower risk of thrombosis and other cardiovascular events in SLE patients. Antimicrobial effects. The drug's antimicrobial properties contribute to its broad use in preventing infections in immunocompromised patients. Current guidelines and recommendations. Major guidelines. American College of Rheumatology, ACR. The ACR strongly recommends hydroxychloroquine for all SLE patients unless contraindicated. The guideline emphasizes its role in reducing disease activity and improving long-term outcomes. European League Against Rheumatism, ILAR. EULAR guidelines similarly endorse hydroxychloroquine for all patients with SLE, citing its effectiveness in reducing disease activity and preventing flares. Lupus Foundation of America recommends hydroxychloroquine as a first-line treatment for SLE, highlighting its benefits in preventing disease progression and organ damage. Dosage and administration. Standard dosage. The typical dose of hydroxychloroquine is 200 to 400 milligrams per day. The dose is adjusted based on the patient's weight and clinical response. Monitoring. Regular monitoring of patients is essential to prevent potential toxicity, particularly retinal toxicity. Annual ophthalmologic examinations are recommended to detect early signs of retinopathy. Safety and side effects. Common side effects: gastrointestinal upset, skin rashes, and headaches. Retinal toxicity. Long-term use of hydroxychloroquine can lead to retinal toxicity. Risk factors include cumulative dose, duration of use, and pre-existing retinal disease. Other risks. Rarely, hydroxychloroquine can cause cardiomyopathy, myopathy, and bone marrow suppression. Impact on SLE management. Antimalarials, particularly hydroxychloroquine, have transformed the management of SLE by reducing disease activity, preventing flares, and improving long-term outcomes. Their role in SLE management is firmly established, supported by decades of clinical research and guideline recommendations. The ongoing use and study of antimalarials continue to refine their application, ensuring they remain a cornerstone of SLE treatment.